Good afternoon, and thank you for joining us in this session. My name is Glen Ewing, the UK Director for Germitec, and I will be your host for today's session entitled How to Effectively Reduce HPV Cross-Contamination Risk in Ultrasound. I would now like to introduce you to our two presenters, Dr. David Webber and Dr. Craig Meyers. The first speaker, Dr. David Webber, will provide a research overview on vaginal ultrasound probe contamination, despite the use of probe covers and low-level disinfection.
Now we go on to vaginal probes, the same issue. You can see here data from Hong Kong, France, Spain, in multiple different studies showing that when you, despite using a probe cover, when you use cleaning and only low-level disinfection, a number of those probes are positive, most importantly for human papillomavirus, a major cause of cervical cancer. But then you can see we have other problems as well, such as mycoplasma, Staph aureus infection, or being found on the probes, again, despite appropriate probe covers and low-level disinfection. So again, we need to emphasize proper cleaning and high-level disinfection. Here is a computer model of how important and what type of risks this represents for an entire country if you use low-level disinfection on endocavity probes. So the goal of this simulation study was to model what would happen if you used only low-level disinfection in France. It was a stochastic Monte Carlo simulation. What were the results? HIV, we would have 40 new HIV infections each year in France by using only low-level disinfection. For other viral diseases, an enormous burden, meaning roughly between 1,600 and 15,000 infections of other viral diseases just in one country. Again, the conclusion, we need to follow guidelines such as the CDC for high-level disinfection of all ultrasound probes. So as we talk about the differences between what high-level disinfection accomplishes, this little schematic demonstrates that. So for sterilization, that is defined as the complete elimination of all possible microbes. High-level disinfection will eliminate all microbes except for high numbers of spores. It will eliminate low numbers, but not high numbers. But it will kill off all the mycobacteria, all the viruses, enveloped and non-enveloped, particularly important for rectal and vaginal probes as HPV. It will eliminate all the fungi and all the bacteria.
The second speaker, Dr. Craig Meyers, will present his expertise in HPV research. He was the first lab to develop a technique to grow natural high-risk HPV 16 and 18 that causes 70% of cervical cancer and other anogenital cancers. He discusses how his research has been applied in changing clinical practice globally in ultrasound probe reprocessing.
So this part of the discussion is human papillomavirus, best research evidence, has played a critical role in effectively changing clinical practice in reprocessing ultrasound probes. So a little background on me and my lab. I was the first ever to be able to grow natural high risk, that is human papillomavirus that is associated with causing cancer. I was the first able to grow stocks of infectious natural virus in the laboratory. And this was a critical result because it allowed us then to start testing human ways to prevent human papillomavirus infection, including the use of disinfectants and their efficacy in killing papillomavirus. We've published hundreds of articles based on these studies, and the bulk of our articles focus on two types, HPV 16 and HPV 18, which, as you know, cause 70% of all cervical cancer and many other anogenital and oropharyngeal cancers. So we have published several papers that support evidence-based practice to integrate HPV research findings with clinical expertise and best clinical practice. We published research that tested HPV against many common disinfectants and showed that many disinfectants are not effective at killing HPV. And I want to point out here that many of the disinfectants that were labeled as high-level disinfectants, we found did not kill HPV. And this is because nobody had ever been able to test these disinfectants in the past. It wasn't until we were able to provide these high level stocks of infectious HPV to do these studies. These research tests include publications that showed that the Trophon EPR device and the Germitec AS1 version 1 and the Kronos AS1 version 2 are proven to kill both HPV-16 and HPV-18 in vitro laboratory studies. So our HPV studies provide best evidence-based research to help clinics to mitigate HPV transmission risk from ultrasound probes. So this is the basic protocols we have used. We've done a few studies using what we would call the suspension test, which is really just taking a small tube and mixing the virus with the liquid disinfectant that we wanted to test. And this can provide some basic evidence on whether the disinfectant can work or not, but it doesn't really recreate the situation that you would see in a clinical laboratory or a clinical institute. And that's where we come to the next part, where it's the carrier test, where we have these discs, and the discs are made of the same material that the ultrasound probes are made out of. And so this provides strong evidence that we can actually put the virus onto these discs, onto the same material that is being used in the ultrasound probes, let it dry, treat it with a disinfectant, and then recover the virus. And we know that without treatment, we can recover all the infectious virus after drying it onto the probe. So we know that the virus can be dried and recovered without any harm to the virus, but adding the disinfectant will then deactivate or kill the human papillomavirus, and our results will show that there's no or very little infectious virus left, and we can quantitatively measure that, and I'll show you that in a minute. And then the final one is where we actually use a probe device. We use the probe handle or the part of the probe, and we can dry the virus directly onto the probe and then put it into a system such as the antigemetics system of Germitec or the Trophon device or some other system, show whether or not those disinfectants and those disinfectant systems can actually deactivate or kill the human papillomavirus. And this again will provide very strong evidence that the disinfectant will indeed prevent the potential for hospital infections due to HPV. So this is the first published study from our laboratory where we were studying disinfectants. And I want to point out here that we use both our natural infectious virus, which we call here the native virus, and we use these a surrogate virus that people like to use in our field. This one is called the quasi-virus. And this is just to point out that you have to use the natural virus to get the real results. That the quasi-virus, in some cases, will look the same, but in other cases will give you data that is not accurate for the native virus. So you cannot use a surrogate particle to do these studies. You also have to be careful on how you produce the virus. We've been working on this for almost 35 years. We know how the virus needs to mature and be structurally stable. So the virus we use is at the highest potency for infection, and so we have done many studies to understand these things. So the graph you're seeing here is, again, in our first study, we just took a handful of known disinfectants, things that are found in hand sanitizers, things that are used in hospital situations, and we tested them to see if they could indeed deactivate or kill human papillomavirus. And you can see some of the differences with the surrogate particles, especially if you look at isopropanol. The surrogate particles were clearly deactivated or killed by isopropanol, but the native HPV, it had no effect on it. It did not deactivate or kill the native HPV in any way. The other thing to point out here is if you look at GTA and OPA, this is what I mentioned before, these have been classified as high-level disinfectants. But what we found was that neither GTA or OPA was able to kill human papillomavirus. So again, those definitions came out before anybody could test human papillomavirus. So you also have to consider, when you're looking at your evidence-based practice, has that high-level disinfectant been tested against native infectious HPV? So what we found was HPV-16 is a highly resistant virus, more so than other non-envelope viruses previously tested. The method we used, we tested the surrogate or the recombinant HPV particles, the quasivirions, versus the authentic HPV-16 grown in three-dimensional organic typic human epithelial culture. We tested the susceptibility of high-risk HPV to clinical disinfectants. The test results showed that the commonly used clinical disinfectants, including those used as sterilants in medical and dental healthcare facilities, had no effect on HPV-16 infectivity. So this made a state that policy changes concerning disinfectant use are needed. So this is a study that we did using the high-level ultraviolet light antigermic system S1. And you can see on the left panel, we're using infectious HPV-16, and on the right panel, we're using infectious HPV-18. The red line is a log-4 reduction in viral titers. That is according to U.S. regulations that require to show a log-4 reduction. And you can see that using the device, we were able to show that log-4 reduction. Actually, if we look at the data closer, we can find no sign of infectious virus remaining after using the device. And we compare that to another positive control, which is hypochlorite or bleach, which again can cause that log-4 reduction. But if you look in the middle where we used OPA, this is been a classical high-level disinfectant. It didn't even reach a 1 log reduction in this study. So the automated antigermics S1 device showed excellent efficacy against HPV-16 and HPV-18, whereas OPA showed minimal efficacy. And our results suggest that healthcare facilities use endocavitary ultrasound probes need to strongly consider the disinfection methods that are effective against HPV. And I will point out that this study was done using discs that were made out of the same material that probe handles are made out of. So our studies, the aim of our study was to test the efficacy of the ultraviolet and as a disinfection of both HPV-16 and HPV-18 using the coupon methods. Coupons are discs. Those terms are used interchangeably. And again, they are made out of the same material that the ultrasound probes are made out of. So high levels of HPV-16 and HPV-18 were dried on the coupons, then placed in the Hypernova Cronus AS1V2 device to inactivate the virus. And the HLD Cronus demonstrated a greater than 4-fold reduction in either HPV-16 or HPV-18, efficiently inactivated the infectious virus. So in conclusion, the HPV research that we have done has shown to be a major driver in changing clinical practice, establishing new guidelines, and clinics adopting new technologies such as the UVC HLD. Published research papers show ultrasound probes are a potential source of HPV transmission, posing a new challenge for infection prevention. Not all research is of sufficient quality to inform clinical decision making. Therefore, you need to critically appraise evidence before using it to inform your clinical decision making, i.e., comparing standard disinfection practices to ultrasound probe reprocessing, high-level disinfection practice. The 3 major aspects of evidence that you need to critically appraise are, and this is the same thing that my colleague Dr. Weber just mentioned to you, is that validity. Can you trust it? Do you understand how they're doing the experiment? Are they using surrogates? Are they using the real thing? Impact. Are the results clinically important? Applicability. Can you apply it to your patient?
We will conclude with a Q&A on some of the most commonly asked questions.
We're we're now at the Q&A portion of the webinar. Our first question, Dr. Meyers, what is the process for a manufacturer to have their medical device tested against HPV, and what is the time frame? And a carry on to that, how do we find out if a company has tested against your native HPV testing protocol?
Well, let me just answer the second part first. That is something you need to discuss with the company directly. That's the way you would find out. Not all things get published, and there are things out there that have been done but haven't been published yet. The first part of the question is, what we do is we have a discussion with the manufacturer. We try to figure out what their needs are, what they want to be able to show, and then we form a protocol with their desired results, but also including controls so that we make sure the validity of the results are correct. And then once we have the protocol approved, we go ahead with doing the study. Once we have all that done, it could take 2 to 4 weeks for us to finish the study.
Thank you, Dr. Meyer. Our next question, we use Trophin 2 for disinfection, and has it been tested to be effective against HPV yet? And that would be to either of our speakers.
So I will defer to Dr. Meyers. The answer is I, off the top of my head, am not aware of the literature for that particular device against HPV. Dr. Meyers may have more information.
I think it's what I said earlier, you have to talk with the manufacturers. I mean, that's the key. You have to hold a conversation with them